Thank you, Dr. Karunaratna and Dr. Dalpadadu. Our next session for the day will be Infections Unmasked, Emerging, Endemic, and Iatrogenic Threats. This will be chaired by Dr. Barana Milavithana, consultant physician at Colombo North Teaching Hospital, past president of the Sri Lankan Association of Geriatrics, along with Professor Tushara Matthias, consultant physician at Colombo South Teaching Hospital, professor at Department of Medicine, University of Shujavardhanapura. Dr. Milavithana and Professor Matthias, this invitation goes to you to conduct the session.
Thank you very much, and welcome to you to the Symposium on Infection Unmasked, Emerging, Endemic, and Iatrogenic Threats. So I would like to introduce the first speaker. He's Dr. Mayur Ramesh. Dr. Mayur Ramesh is actually he's a researcher from Henry Ford Health System, and he specializes in infections in solid organ transplant and has contributed immensely into the research in his field. I would like to invite him to deliver his speech on antibiotic-associated diarrhea. Over to you.
Thank you very much, and thank you to the organizers for having me. In addition, I happen to be an R&D in vaccines and immunotherapy, and I also work on C. diff. So that's one of my disclosures. And the slides were taken from clinicaloptions.com because they were really good, as you can see. So the brief objectives for this talk are, we're going to talk about overview of Clostridium difficile infection with epidemiology, pathophysiology, diagnosis, and management. And then what happens beyond first recurrence, and we'll see if we can finish with some take-home points. Going into epidemiology of C. difficile infection. So C. difficile is a diarrheal illness, and in the past, it tended to be both nosocomial predominantly, but now we can also see it in the community. At least in the Western world, we see it in the community as well. And it manifests because of two reasons. One, you get exposed to antibiotics, as mentioned by many of the speakers before. And the second reason is you get exposed to a healthcare setting. So those are the two main reasons why you end up developing C. diff. And the exposure to antibiotics modifies your gut microbiome for the worse, and because of the C. diff colonization happens, and in the right setting, you develop an antibiotic, C. diff-induced diarrhea caused by C. diff toxin. So C. diff was classified as an urgent threat by the CDC in the United States because, as you can see, from 2011 to 2017, the number of the incidence rate was quite high of C. diff per 100,000 persons per year. And so on an average, we think it is responsible for at least 500,000 cases of C. diff infection just in the United States alone, and about 1/5 of them, about 20% or so, develop recurrent C. difficile infection. So, and C. difficile is the most commonest cause of healthcare-associated diarrheal infection. In 2015, in this paper published in New England Journal by McGill, about like 3/4 of the healthcare-associated GI infections were related to Clostridium difficile infection. As I said before, there's about 500,000 cases, and about 20 to 25% of the cases do develop recurrence. During a brief period between 2000 and 2010, there was, at least in the United States and North America, particularly Canada and the United States, and in some areas of Europe, because of an epidemic strain, and NAP1, that ended up causing a rise in incidence up to 2010, but now it's sort of stabilized, but we still see quite a large number of cases. And the mortality is also pretty high. About 20,000 people die annually from C. diff every year just in the United States. What about recurrent C. diff infection? Recurrent C. diff infection is basically if you, after you achieve that initial cure, when you treat the C. diff with appropriate antimicrobial agent, and then you start developing symptoms again with diarrheal illness, typically, the diarrheal illness is basically 3 or more unformed bowel movements per 24-hour period. And you need to confirm it, you need it at least consistently for 48-hour period. And there are several ways to call unformed stools. You use the Bristol scoring chart. Like 5, 6, or 7, Bristol score means you have an unformed stool. So once that is sort of definition of diarrhea, and then you have to have a positive C. diff test. So in this recurrent C. diff is where your symptoms reoccur again, and the positive test comes back again about 2 to 8 weeks after the previous episode. And nowadays the guidelines also go beyond up to say 12 weeks. If you don't have a C. diff, you don't have further recurrence of C. diff, by 12 weeks, you're considered cured. So between the first episode and the 12-week period, you can either get a relapse of C. diff infection or a reinfection. But within the first 30 days, it's almost all of them are related to a recurrent C. diff infection. And older patients are disproportionately affected by a C. diff because as we get older, our microbiome changes for the worse. And by the time we reach about age 60, 65, our microbiome gets, the density, diversity of microbiome starts going down dramatically. On top of that, people tend to get more exposed to antibiotics. And then that's a ripe recipe for developing C. diff infection. As you can see, there is highest burden of C. diff infection in 65 years or older, over 600 cases per 100,000 population. And in this study where it showed that while in the univariate analysis, you can see there is, with increasing age beyond 65, there is increased incidence of C. diff, but when you do a multivariable model, when you exclude other risk factors such as frailty, healthcare utilization, other things, it sort of steadies off. So it seems like 65 and older is sort of a big age group together that carries a higher risk of C. diff. So going into what happens, why do you get C. diff? So when you look at microbiology of C. diff has a vegetative form, which is the active C. diff, and it can survive in the moist surfaces for up to 6 hours. And the vegetative form is susceptible to gastric acid. So when we take proton pump inhibitors, PPIs, that suppresses gastric acid, that seems to carry a mild increased risk of C. diff. And the vegetative form can be washed out with antibacterial soaps or even alcohol-based hand sanitizers. But the spore form, which survives for months, is completely resistant to antibacterial soaps, alcohol-based hand sanitizers. So if when you enter one of the infection control measures for C. diff is gown and gloves, and also hand washing before and after with soap and water. So alcohol does not touch the spores. So what exactly happens is you get the right age group, for example, older, 65 and above, for example, and you get antibiotic exposure. What ends up happening, your normal gut microbiota becomes more dysbiotic or susceptible microbiota. And so then you acquire C. diff by exposure to healthcare setting or otherwise, even community sometimes. And in the right way, the spores convert into vegetative form, and the vegetative form can be just positive. You can be asymptomatically colonized. You don't have to have symptom at all. But in the appropriate setting where there is significantly less microbiota, the C. diff vegetative form actually starts producing toxin and ends up causing a diarrheal illness called pseudomembranous colitis, and that is C. diff infection. So if you look at normal population, which is in the blue, diverse and abundant microbiome, on exposure to antibiotics, what happens? There is dysbiosis, and on top of that, you ingest the it's orophycal transmission. That's how you ingest the C. diff spores. And then in the right setting, the spores convert into vegetative form, starts producing toxin, and they cause C. diff infection. And if the microbiome changes does not improve, and the spores still remain, which they can remain for a long period of time, you once the effect of antibiotic wears off, you start developing a recurrence or a relapse of CDI. So when you treat them with the antibiotics, you develop initial cure, but unfortunately you start developing recurrences if the microbiome is not improved, which is why we do things like stool transplant. So, and what causes the C. diff, what causes the pseudomembranous inflammation is two key toxins, A and B, of which B seems to be more important. And non-toxigenic C. diff also exists, and that can be detected by PCR, and but they are non-pathogenic. So you can get false testing. So, so how do you test for C. diff? There are multiple different testing you can do. You can check for the genes, the toxin-producing genes. Toxin B gene can be checked with the PCR methodology. But the problem is, even though it's very sensitive, in the order magnitude of well over 95% sensitive, but problem is you get a lot of colonization that can be detected, including non-toxigenic strains. So it cannot distinguish disease from colonization. The toxin test is highly specific, but is only sensitive about 60%. So if the toxin is positive in the right setting of diarrhea, you will consider C. diff as the diagnosis. So the toxin is through an EIA testing methodology, but people tend to do a combination, EIA toxin plus a GDH antigen assay, and the combination lateral flow assay can be done, and the GDH is similar to nucleic acid amplification testing or PCR. It's it's very sensitive but not specific, whereas the EIA test for toxin is very specific but not sensitive. Other things such as toxigenic culture or cytotoxicity assays are generally done in research laboratories or other more research settings because they are very laborious. So, so in centers that used NAT testing originally, they started having overdiagnosis of C. diff infection. So there is no true gold standard at this point of time. So what does the guidelines recommend? The guidelines recommend first is do not check for C. diff if you are asymptomatic. Meaning you have to have diarrhea, as explained that it has to, you have to have at least 3 or more unformed stools in a 24-hour period. Only then you will consider, in the right setting, you consider C. diff. And then once you have a test that is negative, let's assume you had you did a testing methodology that was negative, there's no need to repeat the testing methodology until within the first 7 days of diarrhea, because that is not recommended at all at this point of time. So generally the recommendation, like in most centers in the United States now, use a combination of a multi-step algorithm where they use a combination of GDH plus toxin, and if the GDH is positive and toxin is positive, then it's C. diff in the right setting with diarrhea. If the GDH is positive, toxin is negative, they reflex to a PCR testing, and the PCR is positive, then you have C. diff. If the GDH is negative, toxin negative, you don't have C. diff. So that's sort of a multi-step algorithm that is being used nowadays. So how do you manage? So what are the risk factors for C. diff? Both primary and recurrent disease are sort of similar. The recurrent disease, the biggest risk factor for recurrent disease is the first episode of CDI. If you had CDI once, then your risk for recurrence is there. And if you have C. diff again and again, then the risk increases, which we'll talk about in the next slide. So some of the host risk factors are older age, 65 and older, and immunocompromised state, chronic renal failure, And if you, at presentation, if you're present with severe disease, very severe episode of CDI, that carries a significant risk for further recurrence of a CDI. Or if you have ongoing antibiotic use or an extensive fluoroquinolone use, those things carry a risk, and certain types of strains like O27, the epidemic strain, tends to cause increased recurrence. So if you get the first episode of C. diff, if you put all comers together, the risk of the second episode is at least 25%. Because of the or the lack of microbiome and the persistence of spores. And if you get the second episode, the risk of further episode of C. diff is at least 40%. If you get the second episode, and the risk of further episode is well over 50%. It's somewhere like 65 to 100%. So after that, it's almost guaranteed because your microbiome hasn't recovered at all. So if you to look at treatments, you want to classify a disease as what is severe, what is non-severe. Non-severe is where we use the ZAR criteria, where there is leukocytosis, but the WBC count is less than 15,000 cells per ml, and the serum creatinine is less than 1.5 milligrams per deciliter. Whereas severe is if the Y count is greater than 15,000 and the serum creatinine is greater than 1.5. Fulminant is severe plus hypotension or shock, ileus, or toxic megacolon. That's fulminant CDI. And obviously, there are many medications that are starting to come for C. diff. The original ones were the oral metronidazole, oral vancomycin. Intravenous vancomycin does not work for C. diff. You need to, intravenous vancomycin can be, we use intravenous vancomycin formulation to make into an oral slurry to give it for C. diff treatment, but otherwise giving it IV does not help C. diff at all. Whereas the other medication is oral fidaxomicin. Obviously, you can modify immune system by using an antitoxin monoclonal antibody, non-specific like IVIG, or a more specific toxin B specific antibody such as beslatoximab. There are clinical trials starting to come of toxoid vaccines, like Pfizer is going to start. Pfizer failed in the initial one, Sanofi failed, but they're going to start a new vaccine study soon. And I'm actually working on and long-acting extended like a half-life antibody. The phase 3 trials will come to many parts of the world in the near future. There are obviously dysbiosis correction using FMT, live biotherapeutic products. All those things are coming, and some newer antibiotics are coming. Ridinilazole, the initial study did fail on ridinilazole. Ibezapolstat has completed phase 2, and they're planning for some phase 3. So these are the ones that kill the organism. So the message on this slide is, do not use metronidazole as a primary agent for a C. diff. When we are talking about oral metronidazole. And the rationale behind is manifold. One of them is when in the original tolvemuz is an antitoxin oral drug. When we did the tolvemuz studies, you can clearly see that the orange bar is lower than the blue bar, which is vancomycin. Compared to vancomycin, vancomycin had a better cure rate of C. diff compared to metronidazole. And in this Veterans Hospital study, you can also see that when you use metronidazole as a treatment for C. diff, the 30-day mortality was higher, whether it's a mild to moderate C. diff or a severe C. diff. As you can see that the orange bars are higher than the blue bars. And additionally, why is metronidazole failing is because we have started to see significant metronidazole resistance at this point of time. And we think it's somewhere in the ballpark of 25 to 30% resistance at this point of time. So only about 70 or so % of your patients will develop cure when you use metronidazole for treating C. diff at this point in time. And if your metronidazole MIC is very high, it's greater than or equal to 1 micrograms per ml, then about 60% of them are going to succeed for initial cure, about 40% of them will fail initial cure. So another reason why metronidazole is not recommended anymore. What about oral fidaxomicin or oral vancomycin? They're pretty much identical when it comes to the initial cure, but you can see that fidaxomicin, it works on RNA polymerase, and fidaxomicin is a narrow-spectrum antibiotic as opposed to vancomycin. Vancomycin has additional bystander effect, so it kills out some more anaerobic bacteria, for example. So what ends up happening, because fidaxomicin is narrower, your chance of recurrence, because your microbiome is less modified by fidaxomicin, so clearly the recurrence rates are lower with fidaxomicin treatment as opposed to vancomycin treatment. So what are the current guidelines, whether it's IDSA in US or ESCMID or the ACG guidelines, the Gastroenterology Society guidelines? They all recommend fidaxomicin as the first-line agent, 200 milligrams twice a day for 10 days. And alternative first line would be vancomycin, 125 milligrams oral, 4 times a day for about 10 days. Only in resource poor setting, if there is no other available agent, meaning fidaxomicin or vancomycin, then you may consider metronidazole, knowing very well that 1/4 of your patients or somewhere between 25 to 30% of your patients will fail cure at this point of time. What about fulminant disease? Here, the recommendations are very weak. Based on just clinical experience, we use high-dose vancomycin, 500 milligrams 4 times a day through a nasogastric tube. We throw the kitchen sink at the patient. So we also throw in some IV metronidazole. We don't know, because if you look at the intraluminal concentration of metronidazole, it's extremely low, but we still continue to use that at this point of time. So the data for fidaxomicin for fulminant CDI is also limited. So what about, as you start to recover from fulminant CDI, can you do some step-down therapy instead of getting the high-dose vancomycin? Yes, you can. You could potentially do, as there is clinical improvement of diarrhea, then you can start cutting down the vancomycin to 125 milligrams 4 times a day. So that some of the take-home points relevant to treatment is going to be that fidaxomicin is the preferred agent, and high-dose vancomycin remains the treatment of choice for fulminant C. diff. What about quickly on recurrent C. diff? Irritable bowel syndrome happens. This is secondary IBS. It's a functional GI disorder that also has diarrhea, but does not have the C. diff diarrhea. Basically it's inflammatory diarrhea, so it's mucousy, foul-smelling, that kind of diarrhea. Whereas the irritable bowel syndrome is mostly post-diet, post-eating that you get diarrhea, but it can mimic sometimes close to C. diff. About somewhere in the ballpark of about 15 to 20% of your patients end up getting a post-infectious irritable bowel syndrome 6 months following an episode of CDI. So we need to keep that in mind when we are looking at, is it true recurrence or is it actually so when you look at recurrence, can we use fidaxomicin as an agent? As I told you before, there was further studies using extended pulse dose therapy with fidaxomicin compared to standard vancomycin, where they used much longer duration of fidaxomicin, up to 25 days. And there, recurrence rates were much lower with fidaxomicin compared to vancomycin because of the narrow spectrum of activity. So for recurrence, the first recurrence, the recommendation is consider fidaxomicin as an agent compared to vancomycin. So that's a preferred agent. You can either use standard dose or extended dose because you already developed a recurrence now. So you can do an extended dose. Sometimes we do what is called a tapered dose of vancomycin for a longer period of time, up to about 2 to 8 weeks we can taper at that point of time. We won't talk about beslatoxumab antitoxin drug because Merck pulled it out of the market in end of January of 2025 for commercial reasons, so it's not available anymore to be treated. So we'll skip that. But we are already starting to see the longer they use vancomycin, you're going to develop vancomycin resistance to C. diff as well. So And that is through the VAN-G cluster gene, and that's where that gets turned on to develop vancomycin resistance. We're also starting to see fidaxomicin resistance now, particularly when you start using extended antibiotic therapy. I'll skip besulatoxumab because it's not available anymore to be used at this point of time. So to take home points for recurrent C. diff is fidaxomicin is still preferred, and vancomycin in patients with recurrent CDI episodes can be used as an alternative to fidaxomicin, but it's in a tapering regimen. We used to use besulatoxumab in the setting when it was available, but it's not available anymore. It's an infusion over 1 hour period, but it's not available at this point of time. What about beyond the first recurrence? So for this, we bring in the topic of microbiota transplant. Quickly on human microbiota, there are over 1 trillion different microorganisms, about close to thousands different species in the human gut of the bacteria. There are firmicutes, bacteroidetes, which are good, and there are bad ones such as actinobacteria, proteobacteria, and the remainder as well. And as we go further down the gut, you get more anaerobic bacteria, such as bacteroidetes. When in C. diff, what ends up happening, there is microbiota suppression, there is collateral damage because of antibiotic use, and there is a window of vulnerability. So when you talk about microbiome, what we are talking about is when you look at the people with initial C. diff, they almost mimic like a normal person, but when they get further recurrences, it changes. You lose more of the bacteroidetes and firmicutes, and you start developing more of proteobacteria and the other bacterial phylum. So that's what ends up happening. And when you do FMT, stool transplants, for example, you reconvert that back into the normal microbiome. That's what ends up happening. So quickly, when it comes to vancomycin, as I said, it has collateral damage. So when you use vancomycin in asymptomatic C. diff patients by mistake, what ends up happening is that at least 2/3 of the patients still remain positive for C. diff after when you stop the vancomycin. So all the more reason there is we are trying to move away from any secondary prophylaxis with vancomycin when you have prior history of C. diff, because of the bystander effect. And then when you use antibiotics, when you have C. diff and then you just got treated with C. diff, and then you get exposed to some other antibiotic for some other condition like a UTI or a pneumonia or whatever it is, your risk for a C. diff becomes even higher. That's that window of vulnerability. What is the role of FMT? Fecal microbiota transplant is microbiome replacement. It's at this point the guideline says you need to have at least 3 episodes or 2 recurrences to get to stool transplantation.
Dr. Ramesh, I think with the time constraint, we have to stop here.
Yep. I'll just finish with the two information that we do have market approval for 2 stool transplant products at this point of time. And those are the future that is coming at this point of time. So thank you.
And thank you very much for the comprehensive lecture on C. diff infection. And I think as time has gone, we don't have time to ask questions. And I would like to invite Shara to introduce the next speaker.
Thank you, Bharana. Next, we have Professor Neelika Malavage, a distinguished academic in immunology. Currently serves as a professor at the Department of Immunology and Molecular Medicine at the University of Sri Jayawardhanapura. With esteemed qualifications, including a DPhil Oxon, she holds prominent positions as President-elect of the ISID 2025 to 2027. Her contributions extend internationally as a visiting academic at the MRC Human Immunology Unit, University of Oxford, since July 2008, showcasing her commitment to advancing the field of infectious disease and immunology. Over to you, Dr. Neelika.
Thank you so much for the invitation. So I'll talk about an ongoing situation in Sri Lanka, which is we have a chikungunya outbreak, and I think everybody knows many people, not just one person, but many people who've got chikungunya, and maybe some of you in the audience have experienced this nasty illness. So this modeling recently done shows that about 5.6 billion people in the world are at risk of being infected with dengue, chikungunya, or Zika. All three are transmitted by the same mosquitoes. And about 3.4 billion people are in Asia. And if you can see this map, you know that South Asia is the epicenter for all these infections. All three, unfortunately, and although we are ignoring Zika, it's around as well, as some of you may know. So what I'm going to talk about is why are we having a chikungunya outbreak now? Okay, and how can we prevent, what are the options available? Now, when we talk about, okay, what's been happening, everybody knows that we had a large outbreak during the years 2006 to 2008. And after 16 years, we have another large outbreak. But if you look at what has been going around in the world, you can see our neighboring country, India. We have neighbors from India in this conference as well. They've been having outbreaks, and many countries in Southeast Asia have also been having outbreaks. But not in Sri Lanka, or did Sri Lanka have outbreaks during this time, which we will talk about. And this is data from India. So as you can see, if you look at the last 3 years, from 2022 to 24, India in 2022 reported around 150,000 chikungunya cases. In 2023, it's like 200,000, and 2024 around 70,000. So this is obviously all countries underreported because it's difficult to, differentiate chikungunya from other things. But when India has such numbers, grossly underreported, didn't we have any chikungunya during these 16 years? And what happened in 2024 is, in the middle of the year, Karachi started reporting chikungunya. Chikungunya outbreak started happening in Karachi, and they had 500 to 750 cases per day reported from Karachi. Then things happened in Bangladesh. Bangladesh was having a pretty difficult time with dengue already. For instance, in early 2024, the case fatality rates of dengue in Bangladesh were like 1%. Okay, so compare that with 0.05% in Sri Lanka, that's pretty high. Okay, so Bangladesh was already having a bad time, but while they were having a bad time with dengue, they also started having a bad time with chikungunya. So in 2024, the whole region, started getting this outbreak of chikungunya. So now to answer the question, from 2008 until now, didn't Sri Lanka have chikungunya? So this is a very beautiful study with data from Kandy Hospital and Negombo Hospital. Some of the authors are sitting in the audience. And you can see in Kandy Hospital from 2017 to 2018 April, they have recruited 295 patients with 5 chikungunya PCR positive, so that's absolutely confirmed chikungunya. And from Negombo, there had been 300 patients recruited from 2018 April to 2019. Although nobody was PCR positive, 21 patients had IgM, which means, of course, recent chikungunya infection or active chikungunya infection. And if you look at why these patients were admitted to hospital, they were, of course, clinically diagnosed as dengue. In Kandy Hospital, one of these 7 patients who had chikungunya was clinically diagnosed as severe dengue. And in Negombo Hospital, quite 3 patients who had chikungunya were diagnosed as having severe dengue. So I don't know, the paper doesn't describe what criteria these patients were classified as severe dengue. Because you don't get fluid leakage in chikungunya, possibly they didn't have fluid leakage. You don't get severe bleeding in chikungunya, so maybe they didn't have severe bleeding. Possibly we are talking about severe liver damage. Okay, so possibly because of, liver enzymes going over thousands, they were classified as severe dengue. So actually, just to highlight that these chikungunya patients were classified as dengue. And so we did have chikungunya all these years. But of course, things escalated since the end of last year. So this also highlights when you don't look for things, it doesn't mean that they are not there. Okay, or when you look for a lot of things, they are there, it's just that we are not detecting it. Now, as you can see, we have an issue, although we very confidently or not so confidently clinically diagnose dengue, even severe dengue, it could be due to something else. So now, right now, we are having a simultaneous large outbreak of dengue and chikungunya. And especially in early illness, it's quite difficult to differentiate. And this is some of the data from IDH, National Institute of Infectious Diseases, managed by Dr. Ananda Vijayvikrama, Dr. Damayanti Dampiti, and Dr. Suranga, before he jumped boats, and now he's working elsewhere. And also the data was collected by Radhani, who is a pre-intern. So these are PCR positive chikungunya and PCR or NS1 positive dengue. And you can see there are not many differences in clinical features. So these are clinical features in the first 4 days of illness. I mean, dengue patients were more likely to have abdominal pain, chikungunya patients more likely to have small joint arthritis, that is known, but the very significant differences were in CRP level. So this is an ongoing study, so we just have a very small sample size, but I thought it's just good to show this data, that CRP was one of the important factors discriminating. But having said that, we do know that dengue patients also, some of them have high CRP. Now, the problems with difficulty in diagnosing chikungunya and dengue are several. First of all, because you can't differentiate, or difficulty in differentiating dengue and chikungunya in early illness, so some of the patients who are thought to have chikungunya but who actually have dengue are given NSAIDs or steroids. And this is not a good idea in dengue patients. On the other hand, patients who have chikungunya, who very well deserve to receive pain relief, are not given pain relief because who knows whether they have dengue. And if you give NSAIDs or the painkillers for dengue patients, that's going to be detrimental. So this lack of diagnostics is a huge problem. The lack of point-of-care diagnostics. The patients actually do suffer. So this is why we need to have point-of-care diagnostics. This is not a one-off situation. So I know people are hoping that, okay, chikungunya will end soon and then everybody will be fine. But I was just showing you data from Kandy Hospital that chikungunya really never went away. It was just misclassified as dengue. And with how things are blowing in the world with the erratic like weathers and everything. So, I mean, chikungunya is likely to be around. Zika might one day, explode. We have it in low grade. But so this is why we really need diagnostics. Now, coming to the question, I mean, if chikungunya was around, why are we experiencing a large outbreak all of a sudden? Because now there is evidence that it was around. Has a new and more virulent strain been introduced, or has the virus adapted and has enhanced capacity to now suddenly transmit and infect people? So just a little history about chikungunya. So the virus was first identified in 1953 in Tanzania, and then it caused outbreaks in India, several countries in Southeast Asia, and then it spread around the world. And so while it was spreading, of course, then many lineages happen, so there are 4 main lineages. You have the Asian genotype, the Indian Ocean lineage, the East Central African lineage, and the West African lineage. So these, of course, spread, and you see them basically where the Aedes mosquitoes are, which is in the tropics and subtropics. So although chikungunya was around and causing outbreaks, why are we having an outbreak in 2024 and not just us? As I showed you, Bangladesh, Pakistan, India has been having outbreaks for a long time. So we did do whole genomic sequencing. So this was led by one of our postdocs, Dr. Tibu Jayadas. And what we found was the current circulating chikungunya strain is of the Indian Ocean lineage. But it is very different from the one that circulated previously in 2006 to 2008 in Sri Lanka. And so this is the current strain, which is quite similar to the Indian and Pakistan strains. We couldn't compare with the Bangladesh ones because the Bangladesh, there are no whole genomic sequences available. And these are the earlier chikungunya strains, so they actually are quite separate. We also wanted to do a mutation analysis, so we initially looked at the envelope protein. So this is the part of the virus that it uses to get into cells and also where the antibodies bind to. So if you have mutations, significant mutations in this part of the virus, it can have issues with antibody binding because after all, if you get chikungunya, you're not supposed to get it again. But if there are major shifts, that can be an issue. The other thing is, if there are many mutations, it can enhance infectivity or the virus getting into various type of mosquitoes. So this, our current strain has these mutations, two particular mutations in the envelope protein, K211E and V264A, which is a sublineage of the Indian Ocean lineage, which did cause massive outbreaks in Malaysia. And but our strain does have certain mutations that are not there in the Indian and Pakistani strains, and of course very different to the previous one. We also looked at the mutations within the virus, the non-structural proteins. These are important in viral replication and also evading the host immune system. Now, the reason we want to look at this is if the virus mutates quite a bit, then it will enhance viral replication. It might has a tendency to cause maybe more neurological manifestations, more liver damage, but most of the mutations are of course harmless, but it's important to study these. So our ones were very similar to, again, the Indian-Pakistani ones, although we did have unique mutations. So it is important to study these mutations because otherwise we would not be able to understand what is going on, and it is really important to understand with high intensity of transmission, the virus mutates faster, and then it might get certain mutations that we would not like. Now, coming to how can we prevent chikungunya? So there are many vaccines under manufacture, under trial. There are two vaccines which have been developed and are registered. One is a live attenuated vaccine. The other one is a virus-like particle vaccine. But then Moderna is making a mRNA vaccine undergoing phase 1. The ChAdOx platform from Oxford, they've also developed a vector vaccine which is in phase 2. Bharat Biotech from India, they are doing pretty well. Their vaccine is now in phase 3. So we will see more vaccines coming out in the future. But I will just talk on two vaccines which is currently registered. So we have the live attenuated vaccine, IXCHIQ, which is basically registered by the FDA, European EMA, MHRA, Brazil, all those countries. And later after that, then we have the Vimkunya, which is a viral-like particle vaccine, which is again registered in US FDA, EMA, and MHRA. So we have these two vaccines, and these are currently available in Europe, US, UK, and those countries, and of course not in any of the endemic countries where chikungunya actually is. So these are used as travelers' vaccines. So just a bit about these live attenuated vaccines. So this was initially trialed in US in 4,000 something individuals, and after 28 days there was high seroconversion which persisted for 6 months. The vaccine was also trialed in Brazil. I mean, the trials are ongoing. And the interim analysis was recently published in January, showing again at 28 days in Brazil, which is an endemic country, in seronegative individuals, it gave good seroconversion rates. Coming to the adverse effects, I mean, basically the vaccine gave the same side effects like, tenderness, pain, myalgia, all the usual things that people get after vaccines. But if you look at this safety signal here, 5 people, which is not a lot, but 0.2% of people had cardiac issues after the vaccine, but nobody in the placebo got any cardiac effects. So, I mean, this looks like a safety signal, but only a small proportion, so you maybe ignore it. But subsequently, when this after licensing in US, serious adverse events were noticed in people 65 years and older who had other illnesses, which is adverse events related to cardiac causes and neurological causes. Subsequently, what happened was, okay, this vaccine was now also registered in US and Europe, and it was given to more and more people. And then there were 17 people who got serious side effects. So this is after the vaccine only got registered recently and was rolled out recently, basically this year, including 2 deaths in adults of those who had serious adverse effects. So because of this, the pharmacovigilance prac of the EMA has paused this vaccine in individuals over 65 years of age. The MHRA has also paused this vaccine until further information is gathered in aged individuals aged 65. FDA has also paused the vaccine in individuals over 60 because of these safety signals. So I'll finish off with this other vaccine, the virus-like particle vaccine. So that was registered after the initial vaccine. Again, the trials in this vaccine, the trials so far have only been conducted in US, no other country, but the US trials show that there was high rate of seroconversion lasting for over 6 months. And this is now, this is because even children over 12 years were included in these trials. So this vaccine is registered for kids over 12 years and older. So just to summarize, chikungunya, I don't have to say chikungunya is a terrible, devastating illness. All of you know that because we have friends, family who've got chikungunya and not doing, not very happy. And the current circulating chikungunya strain is similar to the strain in South Asia, which is of course not surprising at all. We do have 2 chikungunya vaccines. When I say we, I mean the high-income countries. To be used as travelers' vaccines. One vaccine is paused in elderly people. Now, just before I end, I have this last slide of gaps in knowledge and urgent priorities. One of the urgent priorities, I believe, is point-of-care diagnostics, which is at least, a rapid or lateral flow test which we can to differentiate dengue, chikungunya, and leptospirosis. Because I think when there are outbreaks, you do have dengue, chikungunya. I mean, earlier we didn't have chikungunya, we only had dengue and leptospirosis. And you could sort of, I mean, because you had very high CRP levels and those in leptospirosis, but now we have chikungunya complicating the problem because you still have very high CRP levels in chikungunya now. So it would be really important to have a point of care diagnostics where you can test all 3 simultaneously because some of these diseases can be treatable if you detect early and patients get the right type of care. And then the second one is, important point is we do need to continually do surveillance, which is very much ignored. I mean, we had chikungunya unnoticed until we got the outbreak. I mean, it was there. We know we have Zika. I know Rohita has published about Zika. We have evidence of Zika in the community, but it's not causing outbreaks as of yet in Sri Lanka. That doesn't mean that it's not going to cause outbreak in future. And we have no idea what other, like exotic viruses to Sri Lanka we have, like Oropushma, which I think some of you have not heard the names. But without looking for things, we will not know whether they are here or not. The other thing is, of course, with the ongoing chikungunya outbreak, I mean, we will have quite a significant proportion having chronic arthritis. So we do need to find the right treatment. Randomized control trials addressing chronic arthritis are really not there much. So that is another issue, I believe, because I'm basically speaking to a CCP audience who will take these things seriously and RCTs for chronic arthritis is a must. So thank you. I would like to thank my funding body, especially the A2CARES, Asian American Centers for Arboviral Research and Enhanced Surveillance, which is supporting our chikungunya research. Thank you.
Thank you, Dr. Nilika, for that excellent lecture. Since we have a little bit more time, I'm sure we can entertain 1 or 2 questions.
Originally with the dengue vaccination, we had ADEs and stuff like that, antibody-related disease enhancement. Do you anticipate any one of this? I know that in the studies we did not see it necessarily. Is there any particular immune mechanism that you think that is different in chikungunya that you're not able to see ADE at this point?
Yes, so chikungunya, there is only one virus. I mean, true that there are several lineages, but it's not 4 different viruses. It's one chikungunya virus, and so far data does show that if you get chikungunya once, it does give lifelong protection, unless the virus terribly, mutates or something like that. But the current evidence is you only get it once. So whereas dengue is very different, you have 4 completely different viruses causing, like dengue, which is like 65 to 70% similar. So that's a very big difference between the viruses, and this is why when you get infected with a different dengue virus, it doesn't really neutralize, but enhances in some individuals. But with chikungunya, you don't get the same issue because there is one virus, and just because you get infected with, let's say, in the Indian Ocean lineage, you're unlikely to get infected with another lineage. So far, that's what the data shows, unless things really evolve and there's a very significant difference between these lineages. Zika. So yes, so there have been studies about Zika and dengue in where you have both, like from Latin America, especially in Nicaragua, where they have done longitudinal studies. So what they have shown is if you have dengue, that does protect against symptomatic Zika infection. But if you get Zika first, it tends to enhance dengue. So dengue does protect against Zika, but Zika enhances dengue. So we do have Zika in Sri Lanka, a different lineage than you see in Latin America. I mean the Asian lineage, which is probably why we don't have these issues like microcephaly, but we do need to keep our eye on things.
Thank you, Dr. Nilika. Moving forward with the symposium.
Yes. Next speaker, Dr. Geeta Sivasubramaniam, and she's going to speak on brucellosis. And Geeta Sivasubramaniam is a medical professional currently serving at Associated Clinical Professor in Medicine. And she's the Chief of Infectious Diseases at Department of Medicine, UCSF, Prenso. And this is a record lecture, and probably she won't be available for Q&A. So I would like to ask our IT team to give the recorded lecture. Thank you.
Hello, everyone. Thank you for joining me today. I'm so happy to be here presenting at the Infectious Disease Conference in Sri Lanka. I wish I could be there in person, but I'm also thankful for the Ceylon College of Physicians for organizing this. Without further ado, I'll get started with my topic. I'm going to be talking today on andulant fever, unrelenting challenge, updates in brucellosis. I'm from Central Valley, California in United States, and we do actually see a fair share of brucellosis cases here, and I'll try to share some of those experiences as well. So brucellosis is a neglected tropical disease as characterized by World Health Organization. It's a major public health concern worldwide, especially for persons living in resource-limited settings. As you all know, it's a zoonotic disease affecting both livestock and wildlife, as well as humans. The major reservoirs are dogs, sheep, cattle, goats, swine, camels, reindeer. And the infection goes by many names based on the location where the disease has been identified. These names are like Malta fever, Mediterranean fever, Gibraltar fever, Cyprus fever, undulant fever, and so forth. Because the disease is under-recognized and under-reported, the actual incidence of this infection is not clear. Now, this meta-analysis studied over 1,800 studies on brucellosis between 2011 and 2021. The annual prevalence was estimated to be around 15%. The highest reported countries came from the Eastern Mediterranean countries, including Iran, Jordan, Egypt, Palestine, Syria, and Lebanon, where brucellosis is endemic. More than 500,000 people in these countries are infected with brucellosis annually. Of course, the highest annual reported cases in addition also include West Asia, India, Southern Europe, and Latin America. But the study found that in some of these known endemic areas, the incidence reported was low. Again, this is due to the lack of monitoring and reporting. So despite being established as a zoonotic risk condition worldwide, the number of new cases remains unclear, underreported. So this study tried to estimate the risk of acquiring human brucellosis both globally and regionally. And they used international public data to fill the gaps and used statistical modeling. They used 3 statistical models, and they considered the missing information to estimate the risk of brucellosis globally. So they came up with a conservative estimate of an annual global incidence of 2.1 million, which is much higher than assumed. The study models indicate the heat maps here, as you can see in Africa and Asia, sustain the most global risk and cases, although areas within Latin America and Europe remain of concern. It definitely looks like the incidence and risk is much higher than what we previously thought, and as expected because of the under-recognition and under-reporting. So this is one of the first reports on human brucella infection in Sri Lanka. This was a study of seroprevalence of human brucella infection and associated risk factors among high-risk occupations, such as farmers, veterinarians, abattoir workers in Sri Lanka. They collected a total of 1,294 blood samples from farmers in contact with farm animals, veterinary staff, high-risk categories, as well as some non-contact urban dwellers. The seroprevalence was about 8.4% for human brucella infection. So they used serum standard tube agglutination test using Brucella abortus and Brucella militensis antigens. And the most common species detected serologically in this study was Brucella abortus. And of note, among animals in Sri Lanka, Brucella abortus has been reported as the most common species as well. So farm animal owners, full-time handlers of livestock showed a significantly higher seropositivity than part-time livestock handlers and non-contact groups. Only 53 persons in this study actually ingested raw milk. Moving on to the microbiology, Brucella species are non-motile, non-spore-forming, slow-growing, facultative intracellular gram-negative coccobacilli. The 4 main species that pose threat to humans are Brucella militensis, Brucella abortus, Brucella canis, and Brucella suis, including some of the newly identified human pathogens such as Brucella inapennata, microti, and amazoniensis. There are about 13 recognized species, but these 4 are the main ones that pose threat to humans. As mentioned already, it is an intracellular organism. It's a quick urease reactor, so it does turn urease positive within about 30 minutes. The 3 species, Brucella militensis, with the natural host are goat and sheep. Zoonotic risk is very high. Brucella abortus with cattle and buffaloes, again, the zoonotic risk is pretty high. Brucella suis from pig, wild boar, hare, reindeer, rodents, caribou, again have a high zoonotic risk. The most pathogenic, the highest pathogenicity is in Brucella militensis and suis. Brucella abortus and canis have a moderate pathogenicity. So how do we acquire this infection? So transmission is by direct contact, often with infected animals. Other methods are consumption of contaminated products such as unpasteurized milk, goat cheese, cattle cheese, inhalation of airborne agents. In the US, it is actually one of the most common laboratory-acquired infections, so it poses a significant occupational hazard for lab workers as well, in addition to slaughterhouse workers, veterinarians. Other methods can be indirect transmission, blood transfusions. It can be transmitted transplacentally from mother to fetus. In the US, a lot of the cases that we see are from neighboring countries, particularly Mexico, where products such as fresh goat cheese, sheep cheese, or unpasteurized milk consumption are some sources here. Again, in US, we see a lot of cases, about, I would say, 25 to 30 cases annually from Brucella suis. And these are often from feral swine carriers. Almost all cases are diagnosed in feral swine hunters. So it has a very varied incubation period. The incubation period can range from 5 days to 6 months. Upon ingestion, the Brucella bacteria are carried by the macrophages to lymphoid tissue. From there, they enter the bloodstream, which is often accompanied by the bacteremia and in the acute febrile phase. From here, it has a predilection for reticuloendothelial system, so it often is found in organs such as liver and spleen, but also numerous other locations such as joints, kidneys, heart, and genital tract. Now, brucella has this unique ability to penetrate and persist within host cells such as macrophages. It uses strategies to bypass the host immune system, leading to prolonged infection. I wanted to present a case of this 57-year-old female from Mexico, whom we saw in Fresno a few months back. She came in with a 2-week history of bilateral hip pain and fevers for 20 days, along with constitutional symptoms. She had no preceding trauma, no inciting events. She was a housewife. She, as far as she could remember, did not consume any raw milk or cheese. She does not interact with animals. She does frequently travel to Mexico. When we saw her, she was febrile. She was acutely ill and uncomfortable. She was not critically ill. Her vitals otherwise were stable, except for some expected tachycardia from the fever. She did have significantly limited range of motion in both hips and point tenderness over her sacroiliac joints bilaterally. An MRI of the hips showed fairly diffuse bilateral muscle edema signal around the pelvis and hips, as well as edema in the sacroiliac joint. Not a lot of effusion or synovitis in the area. We did get her brucella serology, and in our center, it is sent out for an ELISA. We did not send it out for a serum agglutination test. So the test refers out to an ELISA test, which was positive. And in our experience, we've had a lot of false positive serology to brucella. So we drew blood cultures on day 1 and day 6 with notifying lab for concern of brucella. But it, again, even with prolonged incubation, did not show growth, and with addition of additional supplements needed. But day 10 and day 13 blood cultures later grew out the brucella militensis. And prior to blood cultures, we not turning positive, we had actually sent out a Carius, which is a microbial cell-free DNA detection, and that did detect out the brucella as well. So this case sort of exemplifies a kind of a classic presentation we see with brucella. Fever is often present, constitutional symptoms are present, hip involvement, sacroiliac joint involvements are common in the acute phase as well. However, blood cultures are only intermittently positive and may not be a reliable source for diagnosis. So serology and other modes of diagnosis become important. So clinical manifestations-wise, brucella is a multifaceted disease. It affects various organs and has a diverse range of symptoms ranging from mild to severe. The complexity often leads to misdiagnosis, and if untreated, it may transition to a chronic phase, and the symptoms can persist for months or years in chronic phases. Although acute brucellosis does have protein manifestations, fever is invariable. Fever is often present, maybe spiking, accompanied by rigors, relapsing, or mild or protracted, can also cause FUO. Constitutional symptoms, as I mentioned, are generally present. Malodorous perspiration is considered pathognomonic in cases where it is present. Children can actually present with a hemorrhagic anemia in addition to their other clinical manifestations. Physical exam is usually not much helpful. It's generally nonspecific unless focal manifestations are present. Lymphadenopathy and hepatosplenomegaly may be present. It is called undulant fever, oftentimes because this acute form of brucellosis may be characterized with this varying temperature. Temperature usually remains normal during the day, early part of the day, and rises during the evening. It may go on for several days. Then they may have an afebrile period, and then it relapses again with fever. And this can go on. In addition, they may develop focal symptoms along the way if they do develop that. Of course, a lack of appropriate therapy during the acute phase may lead to localization into various tissues, and they may present with those along the course of their illness. So it is known for its complications. Untreated phase does often go into a chronic phase, which may be either focal or systemic. Focal complications often include like bone manifestations, genitourinary manifestations. I'll go through them. But sometimes they may not have a focal system involvement, they may just have chronic persistent symptoms in the absence of any focal signs. This may include malaise, fatigue, fever, insomnia, tremors, sexual disturbances, psychiatric complaints such as depression or anxiety. Focal complaints often include osteoarticular manifestations, genitourinary manifestations. It can involve skin, mucous membranes. It can also involve like liver, spleen, cardiac, of course, with endocarditis. So these are the various chronic manifestations of brucellosis. Bone and joint involvement seems to be the most common complication. Liver is probably involved in majority of cases of brucellosis, although most often this is asymptomatic and their liver function tests are usually normal to only mildly abnormal. When the liver is involved in chronic hepatic brucellosis, sometimes we can see this snowflake sign, which is a distinctive radiological finding, as you can see here, caused by the calcified brucella granulomas in the liver. But as I mentioned, brucella involving the bone is the most common complication and common clinical manifestation of human brucellosis. Incidences in many studies have been between 40 to 80%, even in some of the studies. 3 distinct forms exist: peripheral arthritis, which is more common in children and can involve hand, wrists, knees, ankles. Sacroiliitis, with the inflammation of the sacroiliac joint, as we saw in our case earlier, usually is seen in the acute setting. And spondylitis is often seen in older folks greater than 60 years of age. It is part of a chronic infection, often involves the lumbar spine, and is difficult to treat. Now, the certain studies found peripheral arthritis more common compared to spondylitis, whereas certain studies found sacroiliac arthritis more than peripheral arthritis. The reason for these apparent discrepancies between the studies most likely was because of the different age group involved in the cases within the studies. Positive blood culture in osteoarticular infections is fairly low. So we go by clinical manifestations and rely on serology or disc biopsy or tissue biopsy or cultures for diagnosis. Now, spondylitis can be easily diagnosed with plain radiography, where we see this characteristic Pierre-Pons sign, which is basically the anterior superior part of the segment of the vertebral body is affected, giving this step sign, and it kind of mimics a parrot's beak. This is the destructive appearance of the spine in the anterior superior angle of the vertebra, and it's often associated with osteosclerosis around it. And that gives that parrot beak appearance, and it's considered classic for osteoarticular brucellosis. The reproductive system is the second most common site for focal brucellosis. Epididymoorchitis is the most frequent genitourinary complication in men. It can be confused with testicular cancer or even TB. Brucellosis during pregnancy does pose a substantial risk for spontaneous abortions, as well as intrauterine transmission of the infection to the infants. Brucella endocarditis is less common, usually less than 2% of the cases, but it accounts for majority of brucella-associated deaths. Usually involves aortic valve and typically requires surgical replacement. Aortic and iliac involvement, again, can be very life-threatening. Some risk factors are male gender, older age, atherosclerosis, and smoking. This study of about 273 cases of brucella endocarditis found that younger men were more prone for brucella endocarditis as opposed to aortic involvement, which was more common in older men. The serum agglutination titers of more than 1,280 could be indicative of an advanced endocarditis, and was considered a risk factor for mortality as well. Including streptomycin or gentamicin in treatment regimens in this study was associated with better mortality for brucella endocarditis. Neurobrucellosis is also fairly rare, maybe in 5 to 7% of the cases, often does have worse prognosis similar to endocarditis. Patients may present with behavioral changes, they may present with meningitis, peripheral neuropathy, cranial neuropathies, myelopathy, seizures, or strokes. Diagnosis often relies on different serological testing. ELISA proves to be more beneficial in neurobrucellosis cases. Culture remains the gold standard, although sensitivity is low. And I'll talk about the treatment regimens. Typically, they do need a triple drug treatment regimen. The rate of relapse following treatment seems to be about 5 to 15%. So there is a fairly significant rate of relapse. Usually occurs within the first 6 months following completion of therapy, but may occur up to 12 months later. Causes may include inadequate antibiotic regimen, inadequate duration, lack of adherence, or a localized focus which has not been treated with appropriate antibiotics. However, even without the absence of these factors, even with appropriate antibiotic regimen and duration, relapses may occur. And antibiotic resistance in this situation seems to be rare. And luckily, although chronic morbidity is a concern, mortality remains low for chronic brucellosis, except for in patients with endocarditis and neurobrucellosis. These are the three main diagnostic tools we use for diagnosing: culture, serological test, and molecular methods. Imaging and histopathology are adjunctive tools. Absolute like diagnosis of brucellosis requires the isolation of bacterium from blood or tissue samples, but the sensitivity of blood cultures for diagnosis has been between 15 to 70%. Automated blood culture systems are quite effective. Even so, we want to make sure that we are incubating these cultures for prolonged duration, at least 4 weeks. Some resource-limited settings, we still continue to use the Lewis Castaneda method, where both the liquid and solid medium in the same container are used. Bone marrow appears to be more sensitive than blood cultures, but however, of course, the method of acquiring the bone marrow samples may be more invasive. There are two broad categories of serological tests that are used for diagnosing brucella: those that are targeted against antibody production for lipopolysaccharides, and those based on antibody production against other bacterial antigens. Although there are many tests available, standard tube agglutination test, the SAT test, and the ELISA are most commonly used. We here send out ELISA, and we do see a lot of false positives with ELISA. So it's best to actually use two different serological testing, such as either a SAT plus ELISA in these settings. Worldwide, serum, the standard tube agglutination test is most commonly used. SAT titers above 1:60 outside the endemic regions, and SAT titers above 1:320 within endemic regions are considered positive. The downside to the SAT test is it does not detect Brucella canis infections, and it can cross-react with various other pathogens like tularemia, E. coli, Yersinia, Vibrio, and so forth. Positive serological tests can persist for long periods, so it is not always possible to distinguish serologically between active and past infections. As mentioned, we do see a lot of false positive ELISA tests, but ELISA does offer significant diagnostic advantage, especially in cases of neurobrucellosis. The newer molecular methods, many different amplification methods of PCR have been helpful in diagnosing brucella. The Brucella 16S rRNA gene sequences are helpful as well, but they do not allow for species identification. A Bruce ladder multiplex PCR can differentiate the various Brucella species and the vaccine strains as well. And MALDI-TOF has been helpful, promising diagnostic tool, rapid and inexpensive in identification of Brucella species. Carriers, which is a microbial cell-free DNA from blood, can also detect Brucella and has a faster turnaround time, which we had seen in our patient. Unfortunately, it's quite expensive and not available in all resource-limited areas. So for the definitive diagnosis, we need culture of the organism from blood or body fluids or tissue, or a 4-fold or greater rise in Brucella antibody between the acute and convalescent specimens obtained 2 weeks apart. A presumptive diagnosis can be made with the Brucella antibody more than 1:160 in non-endemic areas, and in endemic areas, we do have a higher threshold of 1:320, or by detection of Brucella DNA by molecular methods. In terms of management principles, antibiotics that can penetrate macrophages and can act in the acidic intracellular environment are preferred. We do want to use combination as opposed to monotherapy because monotherapy is associated with unacceptably high relapse rates. And we do want to use prolonged duration of therapy. So the standard regimens for brucella, not focal infections, not spondylitis, endocarditis, or neurobrucellosis, is doxycycline plus streptomycin for the first 14 to 21 days, followed by doxycycline for the remaining 6 weeks, or doxycycline plus gentamicin parenteral for the first 7 to 10 days, with doxycycline continued for the remaining 6 weeks, or doxycycline plus rifampin both for 6-week period. Focal brucella infections need protracted administration, often of triple antibiotic regimens, doxycycline, rifampin, and aminoglycosides. Alternative regimens include Bactrim and quinolone-based combinations. In pregnancy, rifampin becomes the mainstay of treatment in various combinations, as doxycycline cannot be used. Children are also treated with rifampin Bactrim combinations with aminoglycosides. Moving on to prevention, controlling animal illness and preventing its spread to people is the sole method of preventing brucellosis in humans. Food safety, particularly pasteurization, is crucial. Educating farmers to take care of handling and disposing of aborted fetuses, fetal membranes, and discharges, as well as abattoir workers about transmission, especially via skin abrasion. So this education piece becomes very important. Vaccine is available for animals and have been used. Attenuated strains of Brucella melitensis strain for sheep and goats. Brucella abatus strain 19 has been used for animal vaccination in cattle. In the US, RB51 strain has been used, as well as in some Latin American countries. We have actually seen a few cases of vaccine strain associated infections, especially those that consume raw milk, especially important because this strain is resistant to rifampin. A human vaccine has not been yet developed for human brucellosis. So food safety education becomes very, very important. Future directions, controlling animal illness, preventing its spread to people using this One Health strategy is vital in preventing brucellosis. Eradication, unfortunately, largely depends on socioeconomic and political circumstances. Understanding or making some progress in the molecular pathogenesis, vaccine engineering, and post-genomic approaches may lead to some newer preventive inventions. Again, discovery of some new pathways in modifying the acidic environment may also help us in finding some new adjuvant pharmacotherapy. That's all I had for you today. Thank you for listening, and have a good rest of the conference.
So we'll conclude the symposium on brucellosis, C. diff, and chikungunya. And on behalf of Ceylon College of Physicians, IDF, we would like to thank all three speakers for their contribution to the symposium. Thank you very much.